So non-immune fetal hydrops is defined as accumulation of extracellular fluid in tissues and serous cavities in conditions other than RH incompatibility. So it's associated with increase in the skin thickness because of generalized edema in the fetus. So there is edema in the fetus, the placenta is enlarged, and there is fluid basically everywhere. So there is ascites, pericardial effusion, pleural effusion, etc. Most of the times it is associated with RH incompatibility, but non-immune hydrops includes causes other than RH incompatibility. So what are these other causes? There can be chromosomal abnormalities like trisomy, Turner syndrome, triploidy, aneuploidy. Then congenital cardiac disorders like congenital heart block, supraventricular tachycardia, structural cardiac abnormality. Then congestive abnormality like diaphragmatic hernia, renal abnormality, cystic hygroma. Hematological like beta thalassemia, G6PD deficiency, anemia, leukemia. Infections like parvovirus, basically torch infections. Then placenta and umbilical cord pathology, twin to twin transfusion syndrome. So one twin has edema in that. Chorangioma, umbilical vein thrombosis, or twin anemia polycythemia sequence. Then maternal diseases. So uncontrolled diseases, severe anemia in the mother, thyrotoxicosis. Then miscellaneous like CNS malformation, skeletal abnormalities, and idiopathic. So pathology depends on the underlying cause. However, ultimately pathology uh, is because of severe anemia, hypoproteinemia, that is leading to decreased plasma oncotic pressure, asphyxia, increased capillary permeability, and heart failure. So investigations we try to find out any of these underlying causes like by doing QSG, aneuploidy screening, amniocentesis, chordocentesis, chorionic villus sampling. Then in the mother we can check for then go for infectious screening test wherein ASR/CRP raised, lymphocytes will be raised, and on culture you will find the causative organism to be positive. Then we go for maternal blood sugar testing, peripheral smear, thyrotoxicosis, so T3, T4, TSH, Doppler studies, glucose tolerance test, antibody titers, etc. So management is usually we go for termination of pregnancy. This is this is the best option that we have. Otherwise, we can go for transplacental therapy for fetal dysarrhythmias. Then you can give digoxin to the mother, and this will go into the fetus. All drugs given to the mother cross placenta will go to the fetus and produce effects. Or we can go for direct fetal therapy. This can be done by intraperitoneal, intramuscular, or intravascular route. Then fetal transfusion may be given to improve anemia. Then we can drain pleural, pericardial, or ascitic fluid under ultrasonographic management. Then obstetric management, intrauterine paracentesis or thoracocentesis prior to delivery is helpful for easy delivery of the baby and neonatal resuscitation. Then C-section, again we only use it when there are obstetrical reasons. Then ANC steroid has to be given in preterm babies to ensure there is proper lung development. And intensive neonatal care including ventilator support is needed. So prognosis, perinatal mortality rate is still high despite all these precautions and management.